Hello and welcome to the Royal College of Pathologists Guideline Implementation Webinar Programme. My name is Peter Johnston and I'm the College Vice President for Workforce and Corporate Engagement. I'm delighted to be hosting the webinar today, and we've got with us leading experts and authors for the latest guidelines for tissue pathways of gastrointestinal and pancreatobiliary pathology. The authors will be clarifying with you some aspects of the guidelines that people may find tricky to implement, and will offer practical tips and guidelines around clinical scenarios. They'll also be here to answer your questions. I'm very pleased to introduce the panel for today, the speakers and authors of the pathways. The first is Dr. Tim Andrews, who's going to be presenting to you, Dr. Nigel Scott and Professor Roger Feakins. Just before we start the webinar, can I just remind you, please, that the presentation lasts approximately 15 minutes and then another 20 for questions and answers. All the participants will be muted during this time, and so if you'd like to ask a question, please do so using the Q&A function in Zoom. It's the button at the bottom right-hand side of your screen. We will then take those questions and feed them to the authors. And so without any further ado, please let me welcome our speakers. Over to you, Tim. Thank you.
Thanks, Peter. Good morning, everyone. I'm now going to hopefully be able to share my PowerPoint presentation with you, and hopefully everyone can see this first slide. Peter, is that all right?
Yep.
Okay, so as I say, I'm really the new author to this revised pathway. Both Roger and Nigel have been involved in previous editions, and we'll all be very happy to take questions at the end of this presentation. So what did we aim to do in drafting the guideline was to provide a systematic and evidence-based guidance on the handling of a range of non-neoplastic specimens. So the emphasis here is on non-malignant GI and pancreatobiliary pathology. This is an update of a previous publication from 2016, so 7 or 8 years have elapsed, and we've tried to update the literature. We've been through the relevant guidelines from the college and other professional organisations, and we do accept that a number of the recommendations are essentially based on good practice, meaning that perhaps there isn't a strong evidence base for it in the literature, but this is what our experience as GI pathologists would indicate is the best way to approach certain specimens. We've tried to make it in a standard and structured format, concentrating on biopsies where we've looked at the clinical scenario, the sectioning and staining, so how to approach the biopsy in terms of preparation, and then guidance on things to include in the microscopy report. Similar approach for resection specimens, but obviously emphasis on dissection and block taking. I think it's worth just mentioning what we haven't tried to do. So this isn't a cancer data set. We've not talked extensively about or got into debates about whether certain specimens are of limited or no clinical value. We haven't talked particularly about digital pathology, and it certainly isn't meant to be an extensive textbook on GI biopsy or resection interpretation. It's meant to be a practical guideline to provide an approach, as I say, to dealing with this range of non-neoplastic GI and pancreatobiliary specimens. For this presentation, I'm going to start with a couple of general comments and then move on to some selected areas which we felt are either areas where the guidance has changed or areas which are perhaps encountered as difficulties in day-to-day practice. So first general point, and I would hope this goes without saying, that clinical information and good communication between pathologist and requesting clinician are essential in the handling of these specimens. And certainly the interpretation of non-neoplastic and inflammatory pathology requires accurate clinical information, particularly perhaps thinking about the context of inflammatory bowel disease, and obviously past medical and drug history are particularly important. It's important that this information is easily available. And again, we'd advocate that it's provided to the pathologist as opposed to them having to go hunting for it in the medical record or other clinical systems. If the opportunity arises, having a clinico-pathological conference meeting is certainly helpful for discussion of these cases. And as we will emphasize occasionally, you do sometimes have unexpected findings. So, for example, a non-neoplastic case actually turns out to be neoplastic. And obviously, there should be a means to alert colleagues to these unexpected findings in line with college guidance. The other thing which I think it's worth stressing at the outset is the importance of macroscopic assessment. A lot of the guidance here does relate to the macroscopic assessment of these specimens. Increasingly, dissection of cases may be delegated to another individual, meaning that as the reporting pathologist, you may only see the slides. You may never have seen the gross specimen. And I think this is something that it's worth considering in terms of ensuring that perhaps a photographic record is available, or an opportunity is taken to look at the intact specimen to aid in reporting. Obviously, the recommendations in this document can be used as the basis for local SOPs to guide dissection, and we would emphasize that there should be some mechanism for auditing and reviewing this practice. Perhaps just thinking about some real pitfalls. These are all, I suppose, my examples of things that you've come across. What's been described as a slightly dilated appendix actually turns out to be a low-grade appendiceal mucinous neoplasm, and obviously that would be dissected according to the relevant college data set. A disrupted gallbladder in an elderly patient. It was a subtotal cholecystectomy described as a difficult operation, actually turned out to be a perforated gallbladder cancer. And a case described as fibrotic diverticular disease actually turned out to have dual pathology of both diverticular disease and an incidental adenocarcinoma. So again, just emphasizing the importance of macroscopic assessment, and that this tissue pathway does provide a template to guide that. Now going to move on and talk briefly about 6 areas where either the guideline has been significantly expanded or updated, or perhaps which, in our view as the authors, were perhaps areas of practical difficulty. So firstly, to talk about dysplasia in the GI tract, and with the exception of the anal squamous mucosa, all sites in the GI tract have now adopted a 2-tier system, so low or high-grade dysplasia, and that should be used at all sites. The use of p53 immunohistochemistry may be helpful in differentiating between reactive and dysplastic epithelium. However, we do not feel the evidence for its application to every case is made. And Ki67, again, may be used in this context, but the evidence for that is not strong. The term indefinite for dysplasia is entirely appropriate where there is genuine doubt, but obviously it would seem best practice to try and avoid using this, trying to make a definitive diagnosis where that is possible. And we've also recommended that dysplasia should be double reported in all settings except colorectal polyps, so Barrett's, gastric dysplasia, dysplasia in IBD, etc. And I think just on a practical matter, ensuring that the clinical team know how the double reporting is recorded to avoid unnecessary queries. Eosinophilic esophagitis is another area that I've chosen to highlight, and I suppose it's because this business about should you be counting things in biopsies, and I think the answer for eosinophilic esophagitis is yes, we should. With the current definition being a requirement of 15 or greater eosinophils per 0.3 millimeters squared, remembering that has to be in the correct clinical, endoscopic, and other histological features setting. In terms of the histological features, although you don't often get underlying connective tissue, I think seeing fibrotic underlying tissue with eosinophilic infiltration can be quite a useful diagnostic feature. Obviously, endoscopically, it may be entirely normal, or there may be the description of the so-called feline esophagus, or perhaps more commonly furrows, ridges, and thickening. Again, often clinicians will ask for an eosinophil count in follow-up biopsies, and we have suggested that this should be provided, obviously with the caveat that eosinophilic esophagitis is potentially a patchy disease, and so a count of less than 15 may define histological remission, but it could also be sampling error if the patient continues to have symptoms. So again, the importance of clinico-pathological correlation. And here's just a histological image here, and obviously I'm sure everyone will be quite satisfied that this is a good example of eosinophilic esophagitis, the rather sort of hyperchromatic appearance, abundant eosinophils, and perhaps some small microabscesses over here. Choosing just to highlight briefly refractory celiac disease, and this is defined as histological changes of celiac disease persisting despite a strict gluten-free diet for 6 months. Two types: type 1, where you have a polyclonal population of intraepithelial lymphocytes; type 2, where you have a monoclonal population. And I think to highlight this last point, that either hematopathology assessment or perhaps now referral to one of the national centres for refractory celiac disease in either Sheffield or Cambridge should be considered for these cases, obviously in discussion with the managing gastroenterologist. So I say this is a disease which is considered sufficiently rare that it has a national service set up for management. Now, moving on to inflammatory bowel disease, and obviously IBD is a major part of the non-neoplastic workload, and also potentially quite a complex one. It may be encountered in biopsies, and I think we felt the sort of three key areas to address. Is this inflammatory bowel disease, of which the key features would be identifying a basal plasmacytosis and looking for crypt architectural distortion, features that would favour UC, such as continuous disease, being worse distally, and again architectural distortion, features favouring Crohn's disease, non-cryptolytic granulomas if they're present. I think a couple of sort of clinically important pickups in terms of terminology, terms such as non-specific chronic colitis or non-specific colitis or chronic colitis should be avoided, as they don't convey clinically useful information. And again, if there is either a suspicion on the H&E section or a clinical query, then CMV immunohistochemistry may be performed. And again, if very small numbers of inclusions are demonstrated, these are probably of dubious clinical significance. So again, important to make appropriate clinico-pathological correlation. In terms of, and here we have, this is a rectal biopsy patient presented with rectal bleeding, and I hope people would appreciate that you've got crypt distortion, you've got diffuse chronic inflammation. The patient was actually receiving pembrolizumab for esophageal cancer. So again, just a case to emphasize that you do need the correct clinical history, and drug history is also very important, and this applies at all sites in the GI tract, and remembering that if you search hard enough in the literature, you can probably find an example of just about any medication mimicking any condition. So something very much to be aware of, and not simply jumping to a diagnosis of inflammatory bowel disease. In terms of resectional pathology, it isn't so much the guidance having changed, but I think worth emphasizing that it requires thorough representative sampling, looking at both normal and abnormal areas. Longitudinal sections to show transitions and focal lesions may be useful, and obviously there will always be cases which are atypical or unclassifiable. And what we have here is just this is an ulcerative colitis case, and here we have a focal lesion, a dysplastic lesion here, which I think actually turned out to have a small cancer in with it. So in terms of pitfalls in resections, I think it's worth remembering that in the non-neoplastic spectrum, you encounter a wide variety of, if you like, small or I suppose somewhat sort of tidy up specimens, maybe, such as diverted rectum, ilioanal pouch, either specimens from its formation or removal if the pouch isn't functioning, stoma ends, appendectomies, fistula tracts and skin excisions. These are all settings where we would suggest caution in either making a new diagnosis of IBD or altering an established diagnosis. So don't change ulcerative colitis to Crohn's disease or vice versa in these settings. And obviously be mindful of the fact that treatment may impact on what is seen. Another major area of this guidance is talking around polyps, and the text we have here has been significantly expanded, especially around serrated lesions, non-adenomatous colorectal polyps, and lesions in the upper GI tract. Remember that the reporting of the architecture of adenomas, tubular, tubulovillous, and villous, and the subclassification of serrated lesions is still recommended in routine practice, but that it's actually the number of lesions, the size of the lesion, the grade of dysplasia that tends to influence follow-up in the clinical guidelines. But we're still providing a pathology report in this setting. Also, that the correct handling of intact specimens is emphasised to ensure that maximum information can be provided to the clinical team. This is just a rather extreme example. Here we have a nicely pinned out Thames specimen. This is what we would hope to end up with all the layers of the bowel wall clearly visible, nicely inked margins. Unfortunately, and I will say this wasn't really the pathologist's fault. This has been somewhat damaged by diathermy at the time of removal. But as you can see, a much less interpretable specimen, much less useful information is likely to come from that. And so the correct handling of these orientated specimens is emphasised. Finally, just wanting to pick up on, I suppose, an area that people do often ask or think about is to sample or not to sample specimens. So in terms of appendix, we've said yes, but it may not be necessary to embed all the tissue if there's no histological abnormality in the initial sections. Gallbladder, again, although some recent evidence has suggested that macroscopically normal gallbladders may be discarded, it's still recommended that all gallbladders are sampled histologically. And again, hemorrhoidectomy specimens, if they're submitted by the surgeons, these should be sampled, although limited sampling is acceptable. Some cases it may be acceptable not to sample tissue or not sample widely. So, for example, the resection margins in ischemic bowel do not necessarily need to be sampled. And similarly, the resection margins in Crohn's disease, the evidence is moot between sampling and not sampling. It's not necessary to sample the donuts from benign cases. Cases received from bariatric surgery, minimal sampling is acceptable. And again, for benign resections, it's quite acceptable to take a small, and we've suggested 3-node sample to be acceptable. So, in conclusion, this dataset provides an updated, systematic approach to non-neoplastic gastrointestinal and pancreatobiliary specimens. The importance of clinical pathological correlation and communication is emphasised, making sure that the information which is being conveyed back to the clinicians is relevant for patient management. And we've advocated a pragmatic approach where it's safe to do so, but we've noted the importance of macroscopic assessment and the need to be aware of the potential for unexpected findings. So thank you very much. I'm going to stop speaking at that point, and hopefully there'll be some questions. So thank you.
Thank you very much, Tim. That was really interesting, and an awful lot of helpful practical information in there in these guidelines. So thanks very much for that. A number of questions, a lot of things to ask about out of that. Fascinating. But just for a start, there's I hope a relatively simple one, which is about referral. You mentioned for the refractory celiac disease. You mentioned that there were centres, one was in Cambridge, did you say Sheffield was the other one?
Yeah.
But for the rest of the UK, these centres may or may not be applicable. Do you know what the referral rules are around that?
I have to say the only time I've used it, it's been direct contact between the gastroenterologists and the centre, and I think I presume it's an approach to the centre, and then they will decide if they wish to take it.
I mean,
it's more just to be aware of it, because sometimes it was a CPC discussion, and in the end it was the gastroenterologist who actually will contact Sheffield. So I don't know what the formal referral is, but in that case it was clinician to clinician.
Yeah. I mean, mostly in my experience, these sorts of things are on a per patient basis, but you can build up relationships with national centres where and when it's clinically necessary. But so that's fine. Thank you very much.
It seems to be the Sheffield is the centre of all this, but it's not very clear whether it's serving the whole of the UK or whether it's NHS England. To me, anyway.
Well, that is. People set up things like the national centre, but again, they don't know whether it's not clear whether it's UK national or England national. A number of things coming up about blocking in terms of appendices and gallbladders. So, some people have a standard practice for 1 block, 2 blocks, 3 blocks, and blocks in pieces. Do we take different, what's your guidance about that, or do we just use our common sense?
Roger, do you want to take that?
I've always been perhaps a little liberal with this and said, if we want to receive an appendix or a gallbladder and we want to examine it, then we should try and do it as thoroughly as is reasonable. And I think to do that for both of those, 2 blocks is a good thing. The problem is we have such large numbers. There's huge pressure from various sources to reduce the number of blocks, and people say, well, you can perfectly well put everything into 1 block. So I think there isn't actually an answer, as you say. Be pragmatic within the confines of that are around you as a result of your environment. I mean, it sort of leads into the question some of us were discussing earlier: is do we even need to examine a gallbladder? What does it actually show? But assuming we do, I think it's good to have proper sampling, a sample of the neck and the cystic duct margin, and try and find the lymph node. If you can squish that all into 1 block, very good. If you can't, 2 blocks. For the appendix, again, it's a matter of, we could have a very long discussion about it, but if we're going to receive an appendix, I feel we should have the base, the resection margin, we should have a sample of the tip, we should have a sample of something in the middle. And it depends to some extent on whether you're seeing completely abnormal appendix, clearly looks like appendicitis, or as Tim mentioned earlier, it might be a lamin, in which case it's a completely different situation. If it looks completely normal, then perhaps the best thing is to try and sample the whole thing so you don't have to go back to it. But a lot of these questions about the degree of sampling are very much open with no evidence base, unfortunately, is the answer to your question.
Yeah, I think it's a good point, Roger. The other thing just about it is that if we want to block everything, we're essentially doing ourselves out of a job, because if you're going to bacon slice something and shove it all in a block, you really don't need a pathologist to examine it. So I think we have to be careful about that one. Certainly protocols, but we are trained people to look at things, and that's
yes. I know. Perhaps I wasn't being very, very clear, which is I think trying to force, say, for example, your BMSs are probably doing quite a lot of this, or all of it. So to tell them they must only take 1 block seems a little bit restrictive. If they can take 1 block, fine. If they feel they need to take 2 or 3, then I think they should be allowed to do that. That's my view. Yeah.
And I think it is the macroscopic assessment that's important, making sure that if we are minimally sampling stuff, it is truly normal. As I said, I think that's probably one of the pitfalls to be aware of, and as Peter says, making sure we're not doing ourselves out of a job on this one, and making sure that people doing the dissection do have the training and support to make that decision as to what appropriate sampling is. But the evidence basis for the truly normal appendix and the truly normal gallbladder, as Roger says, is not strong either way.
Yeah, I think we have a number of different pressures here, aren't we? Because we're trying to reduce the number of blocks growing through the lab, because certainly in many laboratories, the laboratory staff are struggling to maintain adequate turnaround times and get stuff through the lab in time. So we don't want to overburden them with too many blocks. But on the other hand, we don't want to miss things. So I think we do have to use our expert and professional judgment, which I think on the whole we're pretty good at doing, and we assess the risk of missing something or not missing something. The other thing that I just wanted to mention was that another thing that impacts on this is that some laboratories, including our own, now have auto-sectioners, and that has introduced another constraint into blocking out, because when you use an auto-sectioner, then you have to have a clearance around the tissue in the center. So whereas in the past you may have been able to put several pieces of tissue into a cassette and squash it in, I think as Roger said, but you can't do that with an auto-sectioner. You can put much less tissue in, so you may end up doubling the number of blocks you take if your laboratory uses an auto-sectioner.
Thank you, that's useful help. I think the bottom line there is it's quality we're looking for, not numbers, and so it's really important to use that. I would like to turn to thinking about inflammatory bowel disease. There's a number of questions. We'll start with one that, again, is a tricky one, I think, in practical terms, which is about what do you do with quiescent colitis? What are the definitions, and what, a little bit of architectural distortion here and there. How do we really interpret consistently what we mean by quiescent colitis? I guess we need the history first, that they've had some in chronic inflammatory bowel disease before we start. But just be interested in your thoughts around that.
Shall I reply? Yes. So I think, as you say, you need the history. If you have no history, it's very difficult to make a diagnosis of quiescent inflammatory bowel disease on a biopsy. I think it's impossible. If you do have the history, I'm not quite sure how much we can do when we see a biopsy with mild crypt distortion, maybe some chronic inflammation, which isn't really very convincing. I usually write quite a not evasive report, but I don't say too much. I think you can say to the clinician, there's some cryptarchitectural distortion, mild inflammation. This is likely to represent the known history or reflect the known history of inflammatory bowel disease. But what they really want to know is that there's no activity, they like to hear that, and there's no dysplasia. That's why they're taking the biopsy, and that there isn't something else going on. They're not really asking you to say, I'm sure this is quiescent inflammatory bowel disease, and it is not a bit of mucosal prolapse or something like that. So I think just report what you see, tell them it's not active, tell them it's not dysplastic and it's not something else, rather than trying to make a clever diagnosis in that setting. Sometimes it's a bit more convincing, and you can say this really does look like inflammatory bowel disease, but again, there's no activity or dysplasia. I hope that answers the question a little bit.
Yeah. Sorry, can I just interject there, if that's all right? Yeah, I agree with that, Roger. But there is a trap you can fall into here, and I myself have fallen into this trap, and I've seen other people fall into it, where you get a set of biopsies from somebody who is said to have a history of ulcerative colitis, and the biopsies are normal. And the danger is then the danger is that you just say, well, this is consistent with quiescent ulcerative colitis.
No, not if it's normal. No.
No. This is what I'm saying. That the temptation is to do that, but then you go to a CPC and you review all the previous histology, and in fact they never had ulcerative colitis, or they had microscopic colitis, which I've seen on several occasions. So I think Roger will back this up, that when I see a set of normal biopsies, I say it's normal, and I don't call it quiescent inflammatory bowel disease.
Absolutely right. I forgot to put that part of the answer in, and that's 100% right. Yeah.
Thank you. That's useful clarification and very important principle there. Report what's in front of us, not what they want us to say. I think that you mentioned, Roger, in your answer, you talked briefly about dysplasia, and so there's a few questions about dysplasia in the questions that are coming in. So again, dysplasia is straightforward when it's obvious, but it's the ones on the borderline between where is it that it's not quite enough, or what are the criteria that say, okay, this is low-grade dysplasia, as opposed to it's not dysplasia? And again, in a similar vein, what is the value of P53, or is there a value to P53 and or P67, I guess, in determining how you make that, or which part of that fence you are associated with, on top of it or on either side, I guess?
Okay, well, I could do a whole lecture on this, I suppose. Shall I talk?
Yeah.
Is that all right?
You've got 3 minutes.
So we'll initially just mention in conventional adenomatous type dysplasia, which is most of what we're talking about. I think, yes, if you see unequivocal low-grade dysplasia, call it that. If you're not sure, then the term indefinite for dysplasia is very useful. I know some of our colleagues are very keen on that term. The clinicians don't like it, but if we can't make up our minds, we can't make up our minds. That's fair enough. We have to tell the clinician it's too difficult. We can't decide if it's inflammatory atypia or dysplasia. There's no shame in that. The important thing is that's not a very low-grade dysplasia. It's not an intermediate category. It's a parking point where you say, I'm not sure what's going on. That's what indefinite dysplasia means. Is P53 useful? Unlike Barrett's, I think most people are not yet advocating P53 as a way of deciding if something, or confirming if something is dysplastic or not. So Barrett's is a big controversial area. We don't really recommend it in inflammatory bowel disease. I don't think it should. Personally, I don't use it. I never use it. If I see it from a referral case, I don't rely on it. Ki67, Ki67, even less so. The other problem with this answer, okay, I'll keep it short, is that we have a whole raft of non-conventional dysplasias that some groups are describing now, which are very difficult to see, very difficult to grade, and not very reproducible. So that's a whole other area, which is quite scary. But for the conventional ones, I've given the answer I would give.
Do you want to say anything about serrated change? Sorry, Roger, just while we're on the subject, because I think we do mention that as a sort of one-liner, but I don't know if there's anything to add to that beyond it. It's quite controversial, I guess.
What, the non-conventional?
No, the serrated change in.
Oh, I didn't hear that. Serrated change in us.
Yeah.
Yes, it always comes up with discussions about dysplasia. There is the so-called serrated epithelial change, which I think for decades everyone knows that you can see serrated changes in long-standing ulcerative colitis, and nobody really ever knew what it meant. And there are, again, a few studies showing that there's a higher rate of simultaneous or non-simultaneous dysplasia elsewhere in the colon or near that region in patients who have serrated epithelial change. So there probably is some sort of association. Whether that actual histological change itself is causing it, leading to it, actually means anything in itself is another matter. But I don't think it's easy to report that. Again, I can't think of the correct word, slightly evasive. If I see some serrated change, I'll report it. I don't often say this is likely to represent serrated epithelial change. I will say there's serration of the epithelium in this biopsy, just so we've recorded it. I don't know what everyone else does.
Okay, thank you very much. Just before we leave the lower GI tract, there's a question about a comment I think you made, Tim, about cryptolytic granulomas, and a query about whether what value can be ascribed to why is non-cryptolytic granuloma not clinically valuable in Crohn's colitis? Although, there are many causes of finding granulomas in the GI tract. Again, it's context specific, I suppose, here, but it's about, what are we doing with granulomas in Crohn's?
Because I hope it came over. It is non-cryptolytic granulomas are said to be, and I think in my experience quite a sensitive marker of Crohn's disease. So it's important to make sure they are truly non-cryptolytic when you see them. Again, clinical context is important because obviously granulomas can be seen in other settings, drugs, sarcoid, infection. But if you've essentially ruled those out, then I think Crohn's disease goes to the top of the list. And Roger, I hope would support that.
Yeah. Well, yes. I mean, non-cryptolytic is very useful.
Yeah.
Cryptolytic granuloma is still more common in Crohn's than in ulcerative colitis and in many other conditions. There aren't actually any really thorough studies of the predictive value of cryptolytic granulomas in terms of saying whether it turns out to be Crohn's disease, ulcerative colitis, or something else. Someone could do it if they're interested. Brian Warren, who passed away, you heard of Brian Warren if you're a little bit older. Some of the young people won't have met him, but he was a superb GI pathologist, and he was adamant that crypt rupture associated granulomas were not discriminatory. And we all believed him because he was superb, but we don't have much evidence. So,
can I just ask my colleagues, Tim, Roger, and Peter, something that I've seen over the years, and I still don't know what to make of it. Little granulomas, and my feeling is that in Crohn's disease as well, with eosinophils in and around them. Now, it's not parasites. You don't see schistosomes, which I suppose is the first thing to make sure you're not seeing. But little granulomas, and quite strikingly see scattering of eosinophils within those granulomas. And I'm sure I've seen that in Crohn's disease. Have you all noticed that? And does it mean anything? Or is it just a feature of Crohn's granulomas? I've never seen it described.
No, I've never seen it described. I think you see it, but I've not been conscious of that.
Yeah, eosinophils are fascinating. Are they cause or effect? And I always think of eosinophils generally as being there because some T cell has said so. Come along, guys. But the significance of finding lots of eosinophils, sometimes with histiocytes and others, I have no idea. I've not seen that described, and it's something that I certainly have raked textbooks for in the past to try and say, well, what is the significance of this here? But I've not found anything that's been helpful in that regard.
Eosinophils are, I'm skeptical, but there's, again, very little. Often papers are contradictory on the value of eosinophils in terms of diagnosis, in terms of prognosis, and so on. So I would be cautious with eosinophils. Yeah.
Mm-hmm. I will tend never to put much weight on it, but it does. It goes round and round in your head sometimes. There's so many of these things; they must mean something.
Exactly.
The answer's always there if we could only but interpret it. Just before we leave this context, there's a question about superficial terminal ileitis. And I mean, we know we spent a lot of time trying to persuade them not just to biopsy the terminal ileum to prove that they were there. But when they do that and then we find something and there's nothing else anywhere else, what do we make of that finding? It's not that uncommon, I don't think, to find actually, but it's again one of those irksome things. Does it mean anything?
Tim, Nigel? Do you think?
I think it depends how you find. I mean, I think you see a few neutrophils in if you look hard enough in quite a lot of terminal ileal biopsies. And I tend not to make anything very much of it unless you're sort of getting sort of things like, well, yeah, granulomas, ulcer-associated cell lineages, sort of hard histological features, as it were. Roger,
yeah, I suppose we have to. Sorry, Nigel, go ahead, please.
No, I'm going to say I'm quite conservative about diagnosing Crohn's disease in those sorts of biopsies. We get quite a lot of biopsies from the terminal ileum where the clinical information is aphthous ulcer or ulceration in terminal ileum, and then you see very little, like you say, maybe a bit of acute inflammation. Quite often you don't see any ulceration, and you usually say, well, could be Crohn's disease, but rule out NSAIDs, etc., infections, and I suspect most of them turn out to be nothing. But like Tim, I'd want to see villous crypt distortion, maybe some pseudo-pyloric metaplasia, more chronic inflammation before I seriously consider Crohn's disease. And hopefully a granuloma, and make sure it isn't TB, of course. But
I think I agree with that, and I think if it's very mild, you just have to give the list of differentials. Probably sometimes best not to mention Crohn's disease or to be very cautious about it when it's mild. When it's more severe, I mean, it sounds really simplistic, but more severe and in a young person, then I would probably say this could be Crohn's disease, but you have to rule out the other causes as well. Yeah.
Okay, just before we leave this one, you mentioned, Tim, in the talk that you said non-specific colitis was not a good thing to do. I guess that a concern that I have in practical terms is that quite often it's difficult to tell whether you've got, what the pattern is in limited biopsies. And there's the concern about labeling people, for example, with inflammatory bowel disease when they actually don't have it. And so it's difficult sometimes, I find, to say, well, yeah, I think this is inflammatory bowel disease, but I'm not sure if it's Crohn's or if it's ulcerative colitis. But particularly when it's new diagnosis in patients who don't have a history. So you get the first one with some inflammation here and there, but it doesn't really have a proper pattern to it. How do you report these? Because I find them difficult.
I think it depends on the degree, and again, Roger is probably more expert on this now. But certainly in my practice, I will either say it's clearly inflamed but not specific with respect to cause. And I won't use the term chronic or active colitis. I'll just stay at a description. If I'm confident it's IBD, but I don't know whether it's UC or Crohn's, I'll say the appearances would favour idiopathic inflammatory bowel disease, and then unclassified in this material would be the term that I would go for.
I agree. I think you have to actually say what you think. People are these days I think the systems are forcing us into ticking lots of boxes and giving lots of lines of black and white information, like it's yes or no or this and that. And I think sometimes you do still have to write text for these cases, as Tim just said. And the more likely it is to be IBD, the more enthusiastic you can be about it. I have a particular problem with in keeping with and consistent with, because those don't give a degree of probability. I know a lot of people use them, but if you can sort of give the clinician some idea, as Tim says, how sure you are or that it could be IBD, that's useful.
Yeah, I think I entirely agree with Roger there. I tend to use words like possible, probable, and this is to try and convey my degree of certainty. Now, whether that makes any difference to the clinician, I really don't know. Perhaps they just see possible and interpret that as this is IBD. But I do try and convey my degree of certainty.
Yes.
Okay. Can we just change the subject then to some more practical stuff, perhaps, about handling biopsy? So there's a couple of questions, and one about, do you think we should be requiring people when they send the endoscopic report, when they send endoscopic biopsies, to give us a copy of the report? Does it help?
Well, the guidelines say we should. Something written by Neil Shepherd and at least one or two other people. As everybody, well, many people know, we often have electronic systems that don't allow that anymore. And I don't know whether we can force busy clinicians who are typing something into their electronic patient record, sending it to us electronically. I don't know if we can find a way of getting them to send us the endoscopy report. But it is very, very useful indeed if we do receive it.
Okay. And the other question around endoscopy was about sizing polyps. Do we record the size of polyps provided by endoscopists, given the fact we often get them in multiple little pieces?
I don't. I push it back to them to work out. If I can measure it histologically, I'll give the size in the report. If I can't measure it histologically, I push it back to whoever's picking that up to work out the size.
Okay. Just going to nip up the GI tract a little bit, back to the esophagus. And again, issues around the diagnostics of goblet cells. We did speak about Barrett's earlier, but someone's asking about doing ABPAS on gastric and esophageal biopsies and how we report the mucin in the goblet cell morphology if we see it. Any thoughts on that one, please?
I think blue mucin without goblet cell morphology is not intestinal metaplasia. That's the usual opinion, unless anybody has a different.
No, I was going to say I have to say I don't think we've used ABPS here, and all the time I've been a consultant here in Liverpool. I think we've always gone on morphology and yeah, as Roger said, just because if you did do one sort of for some reason and you do see a little bit of blueness, that doesn't in my book anyway make the diagnosis. It's morphology. It's an H&E morphology diagnosis.
Yeah. No. Similarly, we don't use mucin stains routinely, and used to talk about columnar blues, didn't they? That was the term given to these, and I agree they're not goblet cells. Although, of course, there are those studies that looked at intestinal differentiation using markers like CDX2 and vilin, which suggested there was some sort of incomplete intestinal differentiation in gastric type Barrett's mucosa. But this, yeah, certainly with regard to morphology and mucin stains, you've got to have the goblet cell morphology.
Okay, and finally, just to finish off, there's a question about numbers of levels for GI biopsies. We tend to use 3 in our place, but what is the general standard, do you think? And when do you stop doing DLs, I guess?
Tim, Nigel?
I was good. Well, I mean, we go for 3, and I think the recommendation in the tissue pathway was 3. I mean, I guess the question as to how far you go is it depends what you're looking for. It depends how confident you are that you've got representative material. I don't know, if I'm chasing a polyp, I might do another 6, but that would be it. I wouldn't go any further than that. I don't know about other people.
Okay.
Yeah, so I agree with this. If it's a polyp, I might chase it a bit further. But I was asked Adrian Bateman once what we should do with those serrated lesions that look like hyperplastic polyps are in the right colon. How many levels should we do? If we do 12 or 15 levels, we might turn it into an SSL. And he said it doesn't really matter if they're small. So anyway, sorry. Okay.
Thank you. Nigel?
Yeah, no, I was going to say, we, like everybody else, we routinely do 3 sections. We would routinely do another 3 if a polyp's been described. And you do pick, there are studies of this, aren't there, that show that you pick up an adenoma or a hyperplastic polyp or whatever in anywhere between sort of 10 and 25% of cases, if you do further levels. In terms of other sites in the GI tract, I suppose it depends how suspicious the endoscopist is. So say if you get a biopsy from the edge of an ulcer and they may say it looks benign, but if they say it looks suspicious or malignant, then I would usually do some more levels on something like that, probably another 3 levels if I didn't see any evidence of dysplasia or malignancy in the first set. Similarly, if they said, thickened linitis-like stomach and you don't see anything in the first 3 levels, then I would do some extra levels. But I couldn't tell you offhand how often you do pick something up in those extra levels.
No, I think that's very helpful. And I guess it's using clinical nous and the information we have, attempting not to leave the diagnosis in the block, as we used to say. But anyway, I'm afraid that we've run out of time and a little bit more in this discussion, which has been really interesting. So thank you very much for that. I'd just like to tell everybody who's on the call that a recording of today's webinar, including the question and answer session, will be available very shortly on the college website. And it'll be a resource there for all members to have a look at and help with the implementation of the guidelines. So if you have colleagues who couldn't join today, please point them towards the website and they will be able to access it there. The professional guidelines team will send round a short survey to everybody to hear back what people have thought, and that feedback is really helpful when it comes to continuing our process. So thank you very much, Tim, Nigel, Roger, for sharing your expertise today, forming a stimulating discussion and doing all the work behind it. Writing this sort of guideline is not something we do on a Tuesday afternoon after tea time. It is a major piece of work and it is much appreciated by the college, but also by all of us who rely on it for our daily reporting tasks. So thank you very much for all of that. For everybody, please remember that our next webinar is coming up very soon. It is Wednesday, the 19th of March, where we will be having a look at the updated guidance for the reporting of central nervous system tumours in adults, and for a bonus, the pituitary gland. So please enjoy the rest of your day, and thank you very much for joining us, and goodbye.